Mary Abernethy, and I'm going to show you how to make a very inexpensive immediate postpartum tubal ligation simulation model. So first off, what you're going to need is some type of a storage container, 16 to 18 quarts, or this one happens to be 16 quarts. You're not going to use the lid, but again, basically this is going to simulate your abdominal cavity of your patient. Within this, we're going to actually place a few things. The first thing is our uterus model. What I've done is gotten a smooth foam 6-inch styrofoam ball, and then my husband was able to use a drill to create tubal ostia. So within this styrofoam ball, there are actually 2 tubal ostia placed bilaterally. That actually represents, this styrofoam ball represents the postpartum uterus. Perhaps the trickiest part of this whole process is to kind of envelope this uterine model with a pair of knee-high hose. If you're smart, you'll get queen-size knee-high hose, because this tends to be the trickiest part of the whole procedure. So once you're able to collect and get your uterus so our 2 tubal ostia are here. We're going to actually use a pair of scissors to create 2 small holes so that we can place a cord through that, which will simulate the fallopian tubes. So again, we have 2 tubal ostia that have been drilled in this styrofoam ball, and this is a 6-inch styrofoam ball. So your fallopian tubes can be made out of various types of cord, anything that basically is braided and has a filament in the middle, such that you can actually fray the ends of it and it will look like fimbriae. So we're going to insert this simulated fallopian tube into the tubal ostia. And I use a shish kebab stick or a chopstick to actually get that to go through. And then in one end, close to where the ostia are, I've placed 2 knots, and that's just so that during the simulation you can't actually pull it all the way through to the other end. So we'll actually place 2 knots on the other side as well. And again, this is just to secure it so that it won't actually pull through the entire model. So now we have 2 tubal ostia as well as the fimbriated ends. The next thing you're going to want to do is to create abdominal organs such as intestines. And what I've done again is used old pantyhose. I've inserted batting material in there. I've either roped off or in some cases tied off those such that it simulates stool within the intestine. So this is assembled. Now what we're going to do is assemble the abdominal wall. So the first layer is the visceral peritoneum, and so I use a material called tulle. So that's our peritoneum. Then at the level of the umbilicus, you actually have an anterior and a posterior aspect of the fascial rectal sheath. And so our posterior aspect, I'm going to use almost a ribbed knit, very thin t-shirt material to create the posterior aspect of that. And again, we'll wrap this around this to basically represent that posterior fascial sheath. Now we have our actual rectus muscles, and I've created them out of red felt, and they're just bands that fit around the model. Next part would be the anterior sheath of that rectus fascial sheath, and I use a mesh, a utility fabric, so that represents the anterior sheath of the abdominal wall of the rectus muscle. I then use batting, any type of polyester batting, to represent the adipose tissue that you would normally find in an abdominal wall. Our final layer is represented by a material called foam-backed headliner. Actually, it is fabric on one side with a foam on the back side, and so we usually will set this down and use this to represent the skin layer and the dermis layer in our model. So we just have used some adhesive backed Velcro to actually complete that so we can wrap it around. And again, here you see that you again have this postpartum uterus that represents a bulge in the abdominal cavity. As we situate, the patient's orientation would be that we would be on one side and we'd have an assistant on the other side. This is a very inexpensive postpartum tubal ligation simulation model that we've created. Now what we'd like to do is have a resident demonstrate the use of the model. All right, thank you.
In this model, we palpate for the fundus of the uterus. Then an incision is made with the scalpel just below the umbilicus. Once this incision is made, the subcutaneous layer is separated bluntly with a hemostat. Palpation is then done for the fascial layer, which is grasped with an Alice clamp and elevated to the level of the incision. Once you have the fascial layer adequately grasped, it is incised with Mayo scissors. A finger is then inserted through this fascial layer and the peritoneum is entered bluntly. You can then extend the fascial incision with Mayo scissors laterally. A finger is then used to bluntly enter the peritoneum. That finger is then used to find the fallopian tube, which is elevated to the level of the incision. The tube is grasped with a Babcock clamp and walked out to the fimbriated end, which can be exposed in this model. The fimbriated end is then returned to the abdominal cavity, and a hemostat is used to pierce through the mesosalpinx, while your assistant hands you a suture on a pass. Ultimately, you will use a second hemostat to again pierce through the mesosalpinx, have your assistant hand you another tie on a pass, thus creating a 3-centimeter segment of the tube that can be tied off and removed. These sutures are tied down bilaterally. Once this tie is complete, the end is grasped with a hemostat and the suture cut short. Again, this is repeated with the second suture to create an approximately 3-centimeter segment of tube to be removed. Both sutures are tagged with the hemostat so that the ends can be visualized for hemostasis prior to returning to the abdomen. The fallopian tube is cut with Metzenbaum scissors. The ends are inspected and, if hemostatic, returned to the abdominal cavity. The second fallopian tube is elevated to the level of the incision and in a similar fashion walked out to the fimbriated end, which is then returned to the abdominal cavity, and a 3-centimeter segment of the fallopian tube is cut off. Again, hemostats are used to pierce through the mesosalpinx, suture passed through and tied to create a segment to be removed. Advantages of this model include that it is inexpensive and easy to assemble, allows multiple attempts on the same model, helps explain the procedure to novice learners in a safe environment, and allows them to become familiar with the steps of the procedure and the equipment needed prior to performing this procedure on a live patient. Additionally, it helps train residents in an environment where this procedure may otherwise not be performed. Once segments of tube have been removed from both sides and the remaining tube returned to the abdomen, attention is turned to closing. The fascia is grasped with Alice clamps and reapproximated with a vicryl suture in a figure of 8 fashion. Once this step is completed, the fascia on the model may be palpated to ensure that it is completely closed. Attention would then be turned to closing the skin, which is done in a subcuticular fashion with a suture of your choice. In the interest of time in this model, we have not shown complete closure of the skin. However, this would be done in a running subcuticular fashion. At completion of the model, you will have the skin closed and 2 approximately 3-centimeter segments of tube which have been removed to complete your postpartum bilateral tubal ligation.